Our next speaker is Dr. Sahid A. Merchant, sir, MD, DM and DNB, Consultant Interventional Cardiologist, Mumbai, and 1978 Gold Medalist, MD, DM, DNB Lecturer, and alumni from prestigious GS Medical College and Chem Hospital, Mumbai, and he'll be talking about polyvascular disease in diabetes and approach.
So thank you organizers for inviting me to this prestigious meeting. I especially thank Dr. Arul Raj, who's been like a mentor for me, and we had very close relationship also with his daughter. I also thank Dr. P.C. Manoria, who had invited me 20 years ago in Bhopal to actually see a patient. So diabetes, as we know, is a silent cardiovascular killer, and we have done close to 15,000 cases in our cath lab, and almost 28% of patients had diabetes. And where we had done peripheral angioplasties like carotids or lower extremities or below knee or heart failure devices, almost 58% of our patients were diabetics. So that makes it very, very interesting. And as you know that there are a lot of cardiovascular complications of diabetes which involve the carotid arteries, the aorta, the heart, both the myocardium and the coronary arteries, also the kidneys with CKD, the renal arteries, the lower limb arteries, mainly the SFA, the tibials, and the diabetic foot. So let me show you a case of a 70-year-old male patient who was diabetic for 30 years. He underwent a routine executive health checkup. And to our surprise, when we did a Doppler, we found that he had a 95% stenosis in the proximal LAD and multiple stenosis both in the iliac artery and in the lower limb arteries. We did a coronary angiography on him, and we confirmed that he had multiversal disease which required multiple stents and also peripheral angioplasty with stents over a period of 3 months. Mind you, this diabetic patient is a businessman, totally asymptomatic. He walked 5 kilometers a day, and he just underwent a routine checkup. And what you have to look at in the future and even today is the silent malignant vascular atherosclerosis in diabetics, which is a very unfortunate disease. And we have to partner with the diabetologist to find the crucial role of early detection of polyvascular disease in diabetic patients. So on stage 1, we performed a multivessel coronary angioplasty on this patient. This was a proximal LAD. How does it play, Dr. Prasanna? Can you play it for me? So this is the severe disease in the proximal LAD. I've used a XB guiding catheter and crossed the stenosis with a BMW wire. You see there's so much calcification in the coronary arteries. He's also got a bifurcation stenosis at the level of the circumflex and the obtuse marginal. This is the balloon dilatation with a 2.5 balloon followed by a 3 balloon and deployment of a drug-eluting stent. So this is the deployment of the stent, and then post-dilated the stent with the balloon, and that was the final result. But you see the kind of calcification and the diffuse coronary artery disease that you find in diabetic patients. So diabetic patients, as far as coronary artery disease, is silent. There is a lot of calcification, it is diffuse in nature, and it's multivessel disease. So that was as far as, and after a few, so that is showing a circumflex obtuse marginal, which is showing a bifurcation stenosis. So after 6 weeks, we did a carotid stenting on the same patient with embolization protection device, which is a filter. Can you play this please? So this is a 5 French headhunter, in which I have used a wire. This is a soft BMW wire, and here you can see a tight stenosis in the internal carotid artery. And this asymptomatic diabetic patient had very calcified carotid artery disease with a very large plaque burden. And there's a filter which is being deployed. I think this has come upside down, but it's the filter which is being deployed. The reason, especially in diabetic patients, we deploy a filter because the plaque burden is so large and it is atherosclerotic that there is a chance that there will be embolization in the cerebral arteries. So that is a balloon dilatation, and after the balloon dilatation we deploy a stent. So this is a absolute stent from Abbott, and it is a closed cell design in the center and an open cell design in the middle, and this is the deployment of the stent in the carotid artery. And then I removed the catheter, and then we also removed the filter. We didn't do a post dilatation here because we got a very good result with the deployment of this stent in the carotid artery. So that is the final result. Can I go to the next slide, please? Yeah. So we also did a peripheral stenting, which was done 2 months later. Next, please. Can you play this? So here what we did is, imagine this patient is totally asymptomatic, and the number of stents, we deployed like 9 stents on this patient, single patient, for 3 in the coronaries, in the carotid, in the peripheral arteries, in the below knee, a drug-eluting balloon in the tibial artery, and mind you, asymptomatic patient who comes for a routine health checkup. This is the internal iliac artery, which had a 95% stenosis, and this is a stent which is balloon mounted, again from Abbott, and that's the deployment of the stent in the iliac artery. And then there was a post dilatation of the stent, and that's the, similarly we did a similar procedure in the left SFA with a post dilatation, and also did a renal stenting because he has a severe stenosis in the renal artery. So what have we learned in this case? So you see the kind of polyvascular disease. We have put multiple stents in the coronary, we have put a stent in the carotid, we have put a stent in the iliac, in both the SFA, in the tibials, a drug-eluting balloon in the peroneal, and also a renal artery stenting. So you'll be surprised in an asymptomatic diabetic patient what kind of malignant atherosclerosis they have to warrant this kind of interventional treatment in the cath lab. So diabetes is a cardiovascular disease equivalent, and the goal is glycemic control to keep the HbA1c less than 7, and that has shown to have cardiovascular benefits. Yes, we have the oral hypoglycemic drugs which have cardiovascular benefit like metformin, SGLT2 inhibitors, gliptin, and GLP-1 receptor agonist. But optimum use of statins, ACE, ARNI, DAP, and beta blockers become very important. What is important to know in diabetes, and because this is a cardio-diabetes conclave, malignant atherosclerosis in diabetes is asymptomatic. It is silent, like I showed you the case of Mr. Hirani, where we put 9 stents in as a polyvascular, and this is about 8 months back. In all diabetic patients, one has to screen for coronary artery disease, for ejection fraction, both reduced and preserved EF, for carotid artery plaque deposit, for renal arteries, for CKD, for retinopathy, for peripheral arterial disease, and for diabetic foot. So we cardiologists, and I'm sure there are many diabetologists in the audience, will have to partner with each other for early and frequent screening of cardiovascular and silent polyvascular disease. Another problem we find in diabetic is heart failure, where the coronary arteries have got very diffuse disease and they are not amenable to stenting or revascularization because the cardiomyopathy is related to microvascular disease and the microangiopathy, which leads to dilated cardiomyopathy in diabetes. So diabetes is observed in approximately 20% of heart failure patients in most clinical trials, and these are the cardiovascular changes in the diabetic cardiomyopathy, which we all know. The arterial stiffness, the LV and diastolic pressures increase, the stroke volume decrease, and there is a diastolic dysfunction. The etiology and the pathogenesis of diabetic cardiomyopathy is mainly related to the hyperglycemia, to the autonomic dysfunction, the mitochondrial dysfunction, the effect of RAS activation, and the metabolic derangement. This is the pathway of the diastolic heart failure, where the heart muscle becomes hypertrophied, thick and stiff, and that is responsible for the diastolic dysfunction. We all know the HFpEF score and how important it is to pick up early diastolic failure in patients who are diabetics. So the initial hyperglycemia and diastolic dysfunction is well known, but it later on leads to hypertrophy, a microangiopathy, and ischemia and heart failure, both with systolic and diastolic dysfunction. All of us know the pillars of the heart failure: reduced TF, ACRB, ARNI, beta blockers, MRA, and now the SGLT2 inhibitors. And we know both from the DAPA heart failure trial and the Emperor reduced primary endpoints the benefit of the SGLT2 inhibitors, both empagliflozin and DAPA, in patients with heart failure. Especially empagliflozin is now shown to improve diastolic dysfunction and heart failure, but the DELIVER trial also showed that dapagliflozin also reduces the risk of cardiovascular death or the worsening of the heart failure in heart failure patients with medium range or preserved LV ejection fraction. Many of the diabetic patients also have advanced heart failure. So if you look at advanced heart failure, where we refer patients for a pump or a LVAD, or we do a heart transplant, you'll be surprised to know that 60% of those patients have got diabetes. So these are the various cardiac devices, including revascularization, ablations, and yes, when diabetic patients present with cardiogenic shock, we have to support them with a mechanical circulatory support, both with an Impella or IABP or a ECMO or a Sentry Mag. This is the HeartMate 3 LV assist device, and we know the heart transplant. Another problem that I face with diabetics is Instantary Stenosis. Can you play this? So this is a patient on which a couple of years back we had put a BVS. Can you play the video, please? Is it possible to play the video? Dr. Prasanna? Oh, you can't play? It's fine. So just go back, please. So you see the severe intimal near, oh, it's playing. So that's the 3D imaging of the OCT, which shows the kind of neointimal hyperplasia that you find in diabetic patients. Therefore, instantary stenosis is almost 15% in diabetic patients. So if it is a very multivessel disease, and if the surgeon is willing to operate, then we prefer a CABG, particularly with complex coronary artery disease like a left main or a multivessel disease or a CTO, multiple CTOs, we prefer a CABG. This is my last case of an 82-year-old lady who's a diabetic with severe claudication of the left limb. Can you play this, please? So we put a stent in the SFA, and then we have put, can we play this, please? Is it possible? Total occlusion of the anterior tibial artery. See the kind of disease, so diffuse anterior tibial artery. Don't have a pointer. Here we have a pointer, but I don't know whether it will work. So, no. So anyway, we dilated this with the balloon. It's a long balloon. So it's a 20 centimeter long balloon, which is 200 mm. And then we deployed 2 stents in the tibial arteries. One was a soluble scaffold, and the second was a drug-coated balloon for this patient. The problem with the metal stents in these tibial arteries is a very high incidence of restenosis. Can you play this? And you see the final result with a very well revascularized vessel. So you see the anterior tibial artery is nicely opened up. And can you... So this is the other case where 44-year-old, he works for Siemens as a manager, diabetic cardiomyopathy, uncontrolled hypertension with renal artery stenosis. He came to us with acute breathlessness in the emergency room. He had severe palpitation and a feeling of collapse, almost arrested with a run of ventricular tachycardia. We shocked him. His resting ECG showed a left bundle branch block. When we did the 2D echo, the ejection fraction was 15%. He had a renal artery stenosis for which we put a stent, and then we put a CRT. We also explained to the family that because he's got a left bundle branch block, the QRS duration is 170. A cardiac resynchronization therapy will help him, and along with the ICD, but we also prepared them for a LVAD or a heart transplant. But fortunately, after putting the combo device, it worked out very well. His ejection fraction improved to 45%, and now he walks 4-5 kilometers a day without symptoms. So, and this is his, can you play this? I'm done, just last slide. Can you play this? So this is just showing a CRT where we put a lead in the RA, a lead in the RV, a lead in the LV through the coronary sinus. This improves the systolic function and improves the cardiac index by producing the synchrony of both the right ventricle and the left ventricle. This mainly benefits patients who've got associated left bundle branch block, or the QRS duration is more than 150 milliseconds. So my take home message today is that diabetes is very dangerous for cardiovascular disease. And I told you it's a silent disease. I also told you there are diabetic drugs with cardiovascular benefits, and we have to use optimum dose of statins, ACE, ARBs, and ischemic heart disease is also common. So one has to look for reversible ischemia. One may need a peripheral angioplasty, multivessel stenting, a CABG, peripheral stents, drug-eluting balloons, DEB. We may need below-knee angioplasty with drug-eluting balloons, or with soluble scaffolds, or even with drug-eluting stents. Carotid stenting, because carotid plaque accumulation in diabetic is a very large burden. Many of them have got hypertension with atherosclerotic plaque in the aorta, ending into the renal artery, resulting in renal artery stenosis. Keep in mind the device therapies, particularly the cardiac resynchronization therapy, especially in heart failure patients with diabetes, ICD. They may have arrhythmias like ventricular tachyarrhythmias, which may need an ablation, and even a LVAD, which is like a pump, where we almost have close now to 11 patients who are diabetics with low EF who already have a LVAD, which works like a destination therapy now with a HeartMate 3, where almost the survival is about 12 to 15 years durability. Heart transplant, and as I told you, the polyvascular atherosclerosis and diabetes needs screening for coronary artery disease, for heart failure, with carotid Doppler, a DSA of the carotid, a renal artery stenosis, a CKD, a peripheral arterial disease, and diabetic foot. In fact, for all my diabetic patients who are diabetic for more than 5 years, when I do a coronary angiogram, I also make a DSA in the carotid. I pull my catheter down to look at the renal arteries, and I make a DSA of the iliac, the SFA, the tibial, the peroneals, and I go up to the foot. So it becomes like a head-to-toe angiography in all my diabetic patients. Thank you so much to all for your patient hearing. Any questions?
Thank you, Dr. Merchant, for giving a overview of this polyvascular disease with excellent clinical material. Professor Sesha, who was here in the morning, used to define us when we were students as diabetes is a diabetic, it's a metabolic vascular disease. I think after your lecture, we have to change it to it's a metabolic polyvascular disease. I think that should.
I think we should ask Dr. P.C. Manoria for his comments. He is a very senior person in polyvascular disease and diabetes.
Hello. 2/3 of patients of myocardial ischemia do not have pain, they have silent ischemia. 1/3 have only angina. So that should always be remembered, and this figure is more in diabetic patients. So it should not be surprising. The second thing which we see in our day-to-day practice is those who go to the gym, we time and again hear they die of myocardial infarction right in the gym. What is important to understand that physical health and cardiometabolic health are not synonymous. You may be physically healthy, you may be very good, but your cardiometabolic health may not be good. So merely going to gym does not mean that you will not develop atherosclerotic cardiovascular disease. And the CT angio of the whole body is a good idea, at least for now that you can see the entire vascular system in a diabetes, as you said, who is of long-standing duration.
So
Thank you so much, sir.
One small,
Yes.
this very often doubts, as a senior interventional cardiologist and seeing a lot of diabetics, do you recommend aspirin for all these patients once we diagnose as diabetics, or
Sorry, you
do you recommend aspirin for these patients as a primary prevention? Because most of the Indian patients have very small diameter of all these vessels and aggressive disease.
Yeah. I think yes, you will need one antiplatelet in diabetic patients of more than 5 years. So those who cannot tolerate aspirin, even a 75 milligram clopidogrel could be a good option in all diabetic patients, especially those who are long-standing chronic diabetics. When I say long-standing, anybody who's a diabetic for more than 5 years.
Thank you, Dr.
Thank you so
Marchand.
much.
We
Thank
move
you.
on to the next session. Now I request you to handle.
Thank you, Dr. Sudhakaran sir, for chairing the session. Thank you, Dr. Sahid sir, for your wonderful talk. I also like to thank Dr. Hariharan sir for his wonderful talk. Now we have a guest lecture chaired by Dr. Aarti Kannan ma'am, MD and Diploma in Diabetology, physician and diabetologist in Tuticorin. Ma'am, I'd like to request you onto the dais for chairing the session.